So thank you so much for having us. We're truly excited to be here to talk to you guys today about menopausal management, as well as provide you guys with all the exciting updates in the field. Going into this, I'll say that I chose to speak on this particular topic because it's something that just comes up so often in my own practice. And to be honest, I felt a lack of comfort managing my own patient's symptoms. I was so fortunate to be able to be paired with Dr. Karen Adams. She's regarded as a master clinician as well as leader and educator in the field. And in fact, so timely, they brought her down from OHSU to create and lead Stanford's new menopause and healthy aging here. We'll talk about more. And, all of us see patients in this state. And unfortunately, the state of care for menopausal patients is hugely lacking, mostly because most of us came to age in our medical careers when the Women's Health Initiative and training was just not there. It was bad. And so practitioners really fell out of comfort and practice taking care of these patients. Today, we have the opportunity to really improve the quality of life of our patients during a notably difficult life stage. And this is really going to happen in half our population. So we're here today to empower you guys. And we're excited to give you guys all the popular information we have.
I love that. I love that context. And I'm super excited to be here with you too, Dr. G. I feel like, you can't see all the people who need to be seen, right? Neither can I. None of us can. And so, all boats rise together. And if we can all do a little better job of taking care of these folks, we're going to really improve the world, I think. So here are our disclosures and conflicts. We're going to talk about both on and off-label uses of drugs. We will identify when we're talking about something off-label. Neither of us have anything to disclose or any conflicts of interest. We do want to acknowledge the North American Menopause Society. Now they're called the Menopause Society. For a lot of the information that we're going to be presenting today. I also want to shout out to Jan Schifrin, my colleague over at Harvard. She shared a couple slides with me, which was so generous of her. And I really think her presentation of some of this stuff is really the best I've seen. So I appreciate her sharing that. And then ISWISH is the International Society for the Study of Women's Sexual Health. And it's a mouthful, ISWISH, but it is a fantastic organization that really focuses on provider education and improving patient care in the area of sexual health. And so anybody who's interested in that part of patient care, I really recommend them highly to you. And then finally, we just want to acknowledge that we're using the terms woman and female in this talk, and we're referring to people who have ovaries and who are experiencing the cessation of ovarian function, either through normal aging or through medical intervention, but that we actually recognize that not everyone uses that terminology to describe themselves if they have ovaries. And we're going to use that term with that understanding of that limitation.
Perfect. So our learning objectives for you today, when we finish this talk, we're hoping that you could get excited about Stanford's new menopause and healthy aging program. It really is a wonderful new resource, both to refer your patients to, but also similar to this talk as a source of both education and empowerment for us providers and our patients as well. We're also hoping that you can be able to list the principal indications for hormone therapy. And as well, we are trying to give you guys kind of really quick language to be able to have those conversations with your patients, the risks, the benefits about hormone therapy to proceed. And as well, just to make sure that it also is an individualized treatment. So just giving you guys kind of the tools to be able to individualize that option and the components within there.
And so this is us, the Stanford Menopause and Healthy Aging team. I'm the director of the program, and the members of the team include Leah Milheiser, who does menopause and sex medicine, and I think is giving one of the talks today. And Amy Vodich is the other member of the team. All three of us have our certification as Menopause Society certified menopause practitioners, which we also recommend to you. It's a course of study and an exam, and then you have that credential, which is super helpful because patients search based on the website for people with that credential. And then our program in Menopause and Healthy Aging has this mission statement that we just wanted to take a moment and highlight, because we support research, advocacy, education, and clinical care that addresses the unique challenges and opportunities that women face in midlife and beyond. Our work is motivated by our conviction that the second half of a woman's life can and should be her best years. And our mission is to give each woman the science-backed resources and information she needs to live a life filled with health and vitality as she ages. And our mission statement includes 4 different pillars. Clinical, which we really are interested in partnering with folks who do other aspects of care for women in this age group. So primary care folks, women's brain, women's heart, women's breast, sleep, nutrition, mental health, all of those things are really important in terms of collaborating so that we can provide the best care for these women. Education is a really important part of our mission statement. We want to educate both patients and providers and provide things like this to really educate providers to take better care of these folks. And then, of course, research and advocacy. So we're very busy, lots to do.
So jumping right in, we thought it was important just to really address head on the Women's Health Initiative and kind of what it is, but also to debunk a lot of the fear behind it. But there is a lot of clinical take homes also. So we're looking to share that with you as well. Perfect. And just a little bit of background on this topic is that there's a dearth of information and medical education on this. From a 2017 study, only 20% of residents had a single lecture on menopause. And here I am, kind of fresh and green out of medical school. And even when in my training between 2012, 2015, I didn't get any training on it. And really, it was more fear around it. And so we really want to empower you guys both from an educational standpoint, but also recognize that it's safe and there are indications to prescribe hormone therapy.
Right. So let's just jump right in. So these are the numbers that hit the New York Times, that hit Good Morning America, that had the phone ringing all day in my clinic when these numbers came out. This was 2002. And this is what the media reported, that there was a 29% increase in coronary heart disease. There was a 41% increase in stroke with hormones. And there was a 26% increase in invasive breast cancer. Sounds terrifying. And so everybody went off their hormones, and there was an entire generation of providers that were not trained and an entire generation of women who didn't get the benefits. And I think it's important that we put those numbers in perspective, because here they are. Here's the 29% increase in heart attacks. Here's the 41% increase in strokes, 26% increase in breast cancer. Can you see my little pointer here as I'm pointing? Okay, great. But here's how those numbers translate to increased absolute risk per 10,000 women per year. 7 extra heart attacks per 10,000 women, 8 extra strokes per 10,000 women. 8 extra cases of breast cancer per 10,000 women. I'm sounding like a broken record, but that's important. 18 extra venous thromboembolic events per 10,000 women. And when I talk about this with my patients, I say, think about 10,000 women. That's like half a football stadium. 8 extra cases of breast cancer. That's not that much. And they go, oh yeah, that's actually not that much. And particularly when a sedentary lifestyle, alcohol intake, obesity, smoking increases the risk of breast cancer orders of magnitude greater than that. Helping people put that in perspective is really important. And if your patient has had a hysterectomy and is on estrogen alone, she actually has a decreased risk of heart attack and a decreased risk of breast cancer. So these folks actually have a better overall risk profile than the people who have to take both estrogen and progesterone because they need the uterine protection. And this slide, oh my goodness, this slide kind of really tells the story, because the women that were enrolled in the Women's Health Initiative were of ages 50 to 79, and they were starting on hormones de novo. So they were putting women in their 70s on hormones. And when you really distribute the data based on age, you see that these younger women, women under 60 or less than 10 years out from menopause, have a very different risk profile than these older women. So that is an important message that really did get kind of lost in the noise around it, that younger women behave differently on hormones than older women. Very important to be aware of. And finally, our last kind of overall view from 30,000 foot slide is this one, that now we've got 18 plus years of experience. And these were people who were given conjugated equine estrogen and medroxyprogesterone acetate for 5.6 years, or conjugated equine estrogen alone for 7 years. And of those women, they continue to follow them. There have been no increase in overall cancer deaths, including breast cancer. There has been no increase in deaths from cardiovascular disease, and a statistically significant reduction of all-cause mortality when hormones are started between the ages of 50 and 59. So important perspective about this is not one size fits all medicine, that you treat those women under age 60 very differently from how you would treat women 65 and above.
Okay, and so we wanted to go over who are the people that you really don't want to give estrogen to, the contraindications to hormone therapy. So in terms of cardiovascular disease, if they have any active heart disease, also if there's a history of stroke, MI, also any blood clots, if they've had a DVT or PE, you don't want to start hormone therapy for them. Anyone with a history of breast cancer, not necessarily family history, but a personal history, this is generally thought of as an estrogen-dependent type cancer. There's also then endometrial cancer on the list of contraindications. In real practice, this is something that Dr. Adams had taught me, that there are implications that if they did have a low-risk endometrial cancer, which it would be okay. And for that, we would recommend, just because it is a little bit harder from the primary care standpoint, to refer to our gynecology colleagues to help us make that decision for your patient. And of course, if any undiagnosed vaginal bleeding, you don't want to start hormone therapy. Relative contraindications would be risk factors for absolute contraindications. But there's also an opportunity to have a risk-benefit conversation with your patient. And again, kind of really individualize that decision with a lot of the great kind of numbers that Dr. Adams had just given us. Perfect. So what are risk factors that you do want to look for? So look at their age. If someone is in their 50s, they obviously have a different risk profile than someone over 60. You also want to look at how many years has it been since menopause. As Dr. Adams had mentioned, that it's considered safe to start someone if they're within 10 years of menopause. So if a patient has gone through menopause at age 55, they still have a 10-year window. So it's either age under 60 or menopausal onset within the last 10 years. You also want to look at their lipid profile, again, for cardiovascular risk factors. Do they have metabolic syndrome? Yes or no? And finally, any underlying coronary artery disease? You can really kind of categorize them as low or high risk. From a PCP standpoint, you can actually use the ASCVD calculator, and the high risk is considered over 10%. So that's someone that you would want to avoid hormone therapy in. And then again, just a reminder that these are things you want to take into account in terms of the patient's individual risk factors to help them make their best decision. Great, so let's start with a perimenopausal case. Very common in my practice, I'm sure similarly in this area. So we have a 45-year-old stay-at-home mom. She's healthy, she's on any medications. She comes in, her cycles has been lengthening. She skipped one period in the past 6 months, and she's really suffering from frequent hot flashes, both during the day, but at nighttime, causing sleep disruption. And she's having mood disorder too. So she just feels emotionally off, shorter temper with her kids, and she comes to us. So yeah, what can we do about it? For vasomotor symptoms, let's talk about vasomotor symptoms. They're generally the symptoms that do bring women into the clinic to talk with us. And hot flashes are the main indication for hormone therapy. It's important to note on this slide that, so on this third line right here, early to late perimenopause. People in their late 40s, up to 80% of those people are hot flushing, and they haven't even stopped their periods yet. Perimenopause is actually the most symptomatic time for mood and hot flushes and everything except vaginal dryness, which will come later, but that's progressive kind of as the hormones wane out. There will be a period where they're the most uncomfortable, and there's actually a lot we want to focus on them, just as far as treatment and what we can do for them.
I just think that's so important, Dr. G. It's like these are women who often are still having, like 50% of the time, having periods, and they are miserable. They're hot flushing all over the place. And, and they often get told, oh, this can't be hormonal because you're still kind of having your periods. And boy, up to 80% of people in the early to late perimenopause could be experiencing this. So yeah. So what do we do for her? So she actually, and this is such an important point, she needs both cycle control and contraception because she hasn't stopped her periods yet. And so maybe she's had a partner with a vasectomy, but maybe not. And so, the last thing you want is somebody to get pregnant unexpectedly. And if you give her hormone therapy, what we used to call HRT, we now call it hormone therapy, it's only about a quarter of the strength of the lowest birth control pill. So it's not going to control her abnormal bleeding. It's not going to turn off her brain ovary cycling, and it's not going to give her contraception. So if you give her hormone therapy, she might get pregnant and she might have breakthrough bleeding all over the place. So the best way to manage somebody in perimenopause is with a low dose birth control pill, assuming she doesn't have any contraindications, or a levonorgestrel IUD, the Mirena IUD, plus an estradiol patch, because the patch will manage her hot flushes, but the IUD will keep her from having breakthrough bleeding, strange unscheduled bleeding, and will give her contraception. So this is very different from someone who is fully postmenopausal, which we will now talk about.
Perfect. So kind of jumping on to postmenopausal, and we have Doris here. She's a 54-year-old special ed teacher. Her last period was about 2 years ago, and she's suffering from frequent hot flushes and night sweats, disturbed sleep, fatigue, irritability. She's tried black cohosh, soy, yoga, meditation, but nothing with effect for these symptoms. Her medical history, hypothyroidism, fibrocystic breasts, and she takes levothyroxine, calcium, and vitamin D for bone health. So just reviewing our objectives, we're going to go over the principle and indications for hormone therapy, what are the contraindications, risks, and benefits, and how to best optimize and individualize hormone therapy options.
So as Dr. G said earlier, the number one indication for hormone therapy is symptom management. And the FDA has approved hormone therapy for 4 indications, and 3 of them are primarily symptoms. One is the treatment of hot flushes and night sweats. One is the treatment of genitourinary syndrome of menopause. The third one is premature menopause, and that is for both symptom control and to prevent the long-term effects of estrogen deprivation, which can be really quite profound if somebody goes through menopause earlier than age 40. And then the fourth one is prevention of bone loss and fracture in high-risk women. So not treatment of osteoporosis per se, but if you have somebody that you're worried about her osteoporosis risk, this is an indication that is FDA approved for the use of hormone therapy.
And so this is a study, the study of women's health across the nation, or SWAN. And it really gives us the data about how women of different races and ethnicities, they experience menopause. So you can see here, almost 50% of Black women will experience severe hot flashes. And unfortunately, it lasts a long time, nearly 10 years. A little over a third of Hispanic women will get severe symptoms lasting almost just as long. And you can compare the different ethnicities below. It's also important to be aware of recent data showing that endometrial stripe thickness is not predictable for hyperplasia in Black women. So you still want to go ahead and get the ultrasound as part of an evaluation. All Black women with postmenopausal bleeding need the ultrasound, but don't use the kind of standard stripe measurement. And all Black women should also have a biopsy because of the higher risk.
Right. And that's because Black women tend to have higher rates of fibroids, and that can obscure that lining, that endometrial stripe lining. And they also tend to have non-endometrioid histology on their endometrial path. And so, so it is really essential to get that ultrasound to rule out fibroids, et cetera. But you definitely want to biopsy that woman as well, even if her endometrial stripe is thin for this reason.
So Dr. Adams, I get this quite a bit. What if my patient just says she wants to tough it out? She doesn't want to treat her hot flashes. What can she expect? And also, are there reasons why I should advise her that she shouldn't just tough it out?
Right. I mean, some women will say that. They'll just say, you know, nobody ever died from hot flushes, and I'm actually kind of scared of hormones. And so maybe I just want to tough it out. And what she can expect with that is 30 to 50% of women are going to get better in about 3 to 5 years, 4 to 5 years. And 85 to 90% will resolve their hot flushes within 7 to 10 years. But that's a long time to wait. And then there are this group of women, about 10 to 15% of women, that we call super flushers, and they will continue to have symptoms for many, many years after menopause. And I think it's important that we talk with our patients about the impact of vasomotor symptoms, because not only are they visible, and sometimes you can actually see someone having a hot flush because her face is getting red and she's sweating through her shirt and all that, but they also can lead to sleep disruption, which can cause mood instability and cognitive decreased performance. And so there seems to be some independent effects of the hot flushes, but certainly the sleep disturbance can lead to all kinds of other downstream effects during the day. In addition, they can cause social isolation. They can cause decreased work productivity and increased absenteeism and difficulty performing well in the workplace. And these are women who are often at the peak of their careers, and they really cannot be having their work performance impacted by their hot flushes. And then there's increased healthcare costs and utilization, and then even some emerging data saying that these can be a marker for future chronic disease risk, including cardiovascular disease, bone health, and dementia. Now, I want to caution you and not jump to the conclusion that treating hot flushes will decrease the risk for those things, but they certainly are markers of future risk and can certainly be something you can keep in mind as you're talking to people about things like exercise and nutrition to decrease their long-term health risks. And then the North American Menopause Society, the Menopause Society, has come out with a position statement. And what their position on this question of treatment of vasomotor symptoms is that they do impact quality of life as well as long-term health risks, and that hormone therapy is the gold standard to treat vasomotor symptoms. And that can be estrogen therapy alone if your patient has had a hysterectomy. It can be estrogen plus progestin, or progesterone alone, which is the best alternative to estrogen, and we'll circle back to that in a minute. The idea, the party line has always been to use the lowest dose that gives relief and periodically evaluate, but we're actually moving more now toward the most appropriate dose rather than the lowest dose, because the lowest dose isn't always the most appropriate dose. And in general, when you're starting somebody like Doris on hormone therapy, the most effective dose is going to be a mid-level patch. So the patch comes in 5 dosage strengths, and you're going to go with that 0.05 dose, which generally is going to give relief of symptoms and the protection that we're looking for.
Dr. Adams, I get this question not infrequently, but they often ask about bioidentical hormones. Could you tell us a little bit more about that so we could guide that conversation with our patients?
Yes. And if your patient says, gosh, you know, Dr. G, I really only want bioidentical. Can you give me bioidentical? You can say absolutely yes, because bioidentical simply means that their body recognizes it, that it was something that was circulating in her bloodstream back in her 20s and 30s. And so that's estradiol, that's progesterone, that's testosterone. All of those hormones are bioidentical. And they are generally plant-based. They're not, chemically derived. And so you can be very reassuring to your patient that you do provide bioidentical hormones in the form of the estradiol patch. Now, bioidentical does not mean compounded. And some people what they're asking really is, can you give me something compounded? And the answer to that should be no, because 34% of compounded hormone therapy has failed FDA quality tests. It's sold without the package insert and the mandated information about indications and risks. Consistency across batches is not always reliable. And in particular, if your patient is using topical progesterone cream or some type of topical form of progesterone, it's ineffective for endometrial protection and it increases her risk for cancer. So the answer to compounded should be no, but the answer to bioidentical can be yes, because all of those FDA products we're offering are bioidentical.
Dr. Adams, something else that I've noticed is that most clinicians choose to go with transdermal, the transdermal form of estradiol. Can you help us to explain why? I think this is actually a fascinating concept.
Right, absolutely. And it's because if you swallow an estrogen pill, the estrogen goes right into the liver and the liver responds by making clotting factors. And we can take that risk down to baseline by doing something other than a pill. So we do a skin patch, or we do gel on your arm, or we do a ring in the vagina, something other than oral. And you can see here, this is all observational data. There are no randomized controlled trials in this area, but we do see an observational data that the transdermal estradiol approach is equivalent to that of a non-oral. It takes you back down to baseline risk for VTE. So that's our preferred approach.
So based on all of that, and this is what I recommended to Doris. So since she's fully menopausal and incredibly symptomatic at age 54, she has no contraindications to hormone therapy. So I started her on estradiol, the 0.05 milligram patch, and then also the oral prometrium, that 100 milligrams. And as you mentioned, also another option instead of the oral progesterone, you could also do a Mirena IUD. And so I said, give her this recommendation and see her back in 6 to 8 weeks. So Dr. Adams, let's say she does really well on this regimen. It controls her symptoms well, and I'm going to see her then subsequently for annual follow-ups. How long would you recommend to keep her on hormone therapy, and when would you consider stopping?
Mm-hmm. Right. And I think that's important that we think about that it's not just her symptoms, it's her long-term health too, but hormone therapy is not approved for cardiovascular, decreasing cardiovascular risk, for example. It really is about symptom management. But this is somebody you're not going to say, okay, come back in 5 years and we'll get your PAP. You know, when you have somebody on hormones, you definitely want to see them once a year just to reevaluate what's going on, how well are they doing on it? Have their health history changed at all? Has risk factors changed? And every year you're going to have that risk benefit conversation. However, we do know that absolute risks increase with age. So coronary heart disease, stroke, VTE risk, breast cancer risk increases with time. But there is no recommendation from any organization to automatically stop at age 65. So we're always going to have that risk benefit discussion, and sometimes just stepping down to the next level down can be a nice way to kind of over a few years taper someone off if you think that you're going to taper them off, but you don't necessarily have to, and you can have that discussion with your patient.
Okay, so let's change the situation a tiny bit. Let's say that Doris did have a history of a blood clot. She had a history of a DVT. How would you recommend to change management for her symptoms?
Right. This is a great time to loop in your friendly neighborhood gynecologist, because this is a little bit more of a complex situation. And it definitely, I think, depends on certain factors. For example, if she were 39, let's say she's going through premature ovarian insufficiency and she had a provoked clot, well, she's got some pretty significant risks for later on in life. And so with the long-term effects of estrogen deprivation. So you might consider a transdermal approach to estrogen, at least until she gets to the average age of menopause. But you're going to factor in that patient's age. You're going to factor in, was it provoked or unprovoked? Did she have a thrombophilia? Is there some other factors that really help you kind of quantify, or at least get a gestalt about her overall risk for a clot? In general, if you decide you're not going to give estrogen to someone with a history of a clot, you're going to want to use a progestin. That is your most effective alternative. It is off-label when used alone, but hot flash frequency and severity are very responsive to progesterone alone. So you can do an oral progestin. You might need to bump it up a little bit more than what you would use for that balancing the estrogen. So for micronized progesterone, you might go to 300 milligrams at night, or medroxyprogesterone acetate up to maybe 30 milligrams daily, 10 milligram tablets to get her hot flushes under control. So that would be your best option if you think that estrogen's not a good idea for that patient.
And so let's consider a different scenario. Let's say that Doris had a history of breast cancer, and we'll kind of walk through what to do there.
That's a big no. That is a big no. And, some people say, well, what if it was triple negative, or what about the estrogen receptor status? In general, somebody with breast cancer, you're not going to give estrogen to, and you're just going to look at other alternatives. So what are those? We have some news for you, which this is a resource that's really helpful. In May of 2023, the Menopause Society came out with a non-hormone therapy position statement, which is really helpful, because there are some people who just absolutely should not be on hormones, and people with breast cancer are in general one of that group. And what do we have to offer for them?
So going over other non-hormonal RX options, so SSRIs, and just to know that the low dose of paroxetine is actually FDA approved. You can also try SNRIs, gabapentin, oxybutynin, and always just kind of think of any of their comorbidities. So would any of these treat other symptoms or other things that they're struggling with? And that can also help you to determine what to start for her menopausal symptoms as well. This is a great resource. I have taken a picture myself, and I would, these are one of those high utilized ones. This is a great source to say, which ones you're going to start at what dose, and then how to titrate that up.
Mm-hmm. Right. This is a wonderful thing just to have on your phone or keep it on your desktop. Yeah. And then we have some also super exciting, really late breaking news that was really just came out in May. So it didn't make it into the non-hormonal position statement, but candy neurons in the brain have been the subject of research interest for several years as a potential place where we could impact people's vasomotor symptoms, because they are co-localized with over 95% of the estrogen receptors, progestin receptors, and androgen receptors in the RQ8 nucleus in the brain. So there's been a lot of research. I love the name of these, the candy neurons and kisspeptin, and all that. I would love to come up with some drug names that impact those receptors. What they came up with, this came out in May, is a thing called fezolinetant, which is also Veoza. It is the first drug of its class that is a neurokinin B blockade or antagonist. And so what it does is it modulates neuronal activity in the thermoregulatory center in the hypothalamus by blocking neurokinin B. And so its efficacy is almost as effective as estradiol, which is so wonderful. It's just a single 45 milligram daily dose. The only contraindications to it are people with end-stage renal disease, people with active liver disease. And you do want to check liver functions at baseline and then at intervals for a while you've got your patient on this drug, because they have seen doubling and even tripling of liver function tests on this drug. That is reversible when you stop people on it, but there is a risk of that. So you want to make sure their liver functions are at baseline normal. And then the only drug interaction that you have to be aware of is CPY1A2 inhibitors. These are not really in common use other than maybe cimetidine, but that can actually interact with the blood level and increase your level of fezolinetant. So you want to be careful about that. And there are phase 4 trials coming down the pike, and these are real world experience trials, and we're hoping that we're going to be a site for that. These are expensive drugs. These drugs run a couple $100s a month, but there is a coupon that's available online, and anybody with commercial insurance should download that coupon prior to going to the pharmacy, and that will really bring down their copay to about 10% of what it otherwise would be. Unfortunately, Medicare does not accept that coupon, so your Medicare patients are going to be paying out of pocket for this. But it's a great option to be aware of.
And Dr. Adams, not infrequently, patients say, they come in taking supplements, in particular like women's herbal formulas that they've found either over the counter or from an herbalist to treat their hot flashes. And would you be able to let us know, is there any evidence behind those, and should we be recommending them?
Nope. That's the answer. Nope. None of these really have been shown to be effective over and above placebo. There are a few lifestyle and behavior interventions that they do discuss in that non-hormonal position statement. And the one that we really want to highlight is cognitive behavior therapy. Dr. G, do you ever recommend cognitive behavior therapy for your patients?
Yeah, for menopausal symptoms, but yeah, everything under the sun. I think that it just really helps with most things.
Right. It helps us live life, right? Everyone should do it. I should do it. You should do it. Our partners should do it. Everyone should do cognitive behavior therapy. And that's really effective for vasomotor symptoms. But unfortunately, a lot of the things that we've recommended over the years, like slow, deep breathing and that sort of thing, not so much, actually, when you look at the randomized trials. But cognitive behavior therapy is something that can be useful. Weight loss, we're always going to talk about that. Clinical hypnosis, it's a little bit harder to access, and stellate ganglion block also does have data to support it, but it's pretty invasive. And now that we have a good pharmacologic option, I doubt that we're going to be recommending that much for our patients. And finally, we really refer you to www.menopause.org, which is the North American Menopause Society website. They have great resources for your office practice, including these Meno notes, which are super cool because you can print them or you can give the patient the link to the website, and they address common symptoms and things that our menopausal patients deal with. So we wanted to make you aware of that resource. And then to wrap up, vasomotor symptoms should be treated. We really should be treating them to minimize other menopausal symptoms and to promote our patients' long-term health. Hormone therapy is currently the most effective treatment, and you're going to prefer to give that in a transdermal form and oral micronized progesterone. An IUD is off-label use, but could be used to oppose the estrogen. The lowest effective and most appropriate dose is generally going to be that 0.05 biweekly patch and 100 milligrams of micronized progestin. You always want to see these patients back at least once a year and don't let them just go away for 5 years. People under age 60 or less than 10 years out from menopause are going to be the best candidates for hormone therapy, and women without a uterus actually have an even more favorable risk profile. If your patient has a contraindication to estrogen, progestin alone is going to be her best alternative, but you also have some other alternatives, which are SSRIs, SNRIs, gabapentin, and now we have this new option, fezolinetant, that be sure to remind your patients about the coupon available. And that's it.
Great. Thank you, Dr. Adams and Dr. G, for that wonderful talk. And thank you for all our attendees for asking all these wonderful questions. I really wish we had more time to get to all of them, but we'll just start with, so if someone has amenorrhea on their IUD, how do you know when they've reached menopause?
Right. Can you hear me?
Yes.
Okay. You don't actually, because the definition is no period for a year. So you're going to go by symptoms. And so hot flushing and night sweats happen about 80% of the time. And so it's generally going to be symptom driven.
Okay. And I understand that those symptoms can also occur during perimenopause, right? So when would it be safe to remove the IUD?
Mhm. Well, yeah, I think safe isn't what I would so much say as useful. IUDs are useful in women in their 50s, 60s, 70s as opposition to the estradiol patch. So some women in their 60s who are on hormone therapy still have an IUD. We are talking in the menopause group about how long to keep a levonorgestrel containing IUD in as opposition for estradiol patches. And we're thinking 5 years is probably the appropriate amount of time to keep the IUD in, even though there is extended use in some other settings for estrogen opposition. We're thinking 5 years for a Mirena IUD or levonorgestrel containing IUD.
Great, thank you. I know you mentioned daily progesterone, and some of our participants have asked, when would you use cyclical progesterone? Another person asked, is 200 milligrams for 10 days for every 3 months enough?
Do you have any thoughts about that, Dr. G, or do you want me to take that?
No. I think that there's two options I would say, and so you could do kind of the higher dose to cyclically, and you can also then kind of induce their period as well. But you can also then do the lower dose 100 for daily throughout, and then you don't have to kind of induce bleeding. But Dr. Adams, I'm not sure if you have any kind of clinical guidelines about which one to choose.
Mm-hmm. I think that's correct. I think that's absolutely right. At the beginning, I really don't want them to have unscheduled bleeding. And so sometimes with continuous a patch and a daily progestin, they might have some breakthrough bleeding. So if I manage that with cyclic a dosing of the progestin, that can be really useful. We call that extended cycling, where every 3 months they get 200 milligrams of micronized prometrium for 10 days. And yes, that's totally adequate and fine. And in fact, you could do that, that if that's your preference, you could do that in that way. And that's the main, I think, limitation of the continuous daily, is that there can be some breakthrough bleeding at the beginning that can be somewhat of a nuisance. It's typically not dangerous. And when I've initiated someone on hormones, I can usually tolerate it for 3 to 6 months or so. And then if they continue to bleed, I would either extended cycle them or work them up for postmenopausal bleeding. But you really want to try to minimize that for folks, because it's such a nuisance to have to get ultrasounds and biopsies and things like that. So anything we can do to decrease unscheduled bleeding is a good thing.
Great, thank you. And so to segue into the next question, many women report an increase in the duration or the amount of their periods as they transition to menopause. How do you decide who to obtain a pelvic ultrasound in for further evaluation, and when we can just reassure them that this is part of perimenopause?
Mm-hmm.
Dr. Adams, that's a good question for myself as well.
Oh, Dr. G, do you want to take that?
Actually, I would actually be curious to hear your response. Actually, I think I'm actually curious myself about when to work it up. To be honest, Joanne, I think that we do expect so many changes during perimenopause that I don't find a lot of indications to get that unless it's severe. We're looking for other secondary sources of bleeding. But yeah, in your practice, kind of what would you recommend for us as PCPs?
Yeah, I don't think you're ever going to regret getting an endometrial biopsy, so if you're thinking about it, it's never wrong to do it. I think that skipping periods and prolonged cycles, I typically think of as normal. Frequent random bleeding, I don't think of as normal. Heavy, gushy, clotty, filling up a pad every hour or two, I don't think of that as normal. And so, then I start worrying about organic causes, adenomyosis, fibroids, polyps, things like that. So I think if they're extending their cycles 45 days, 60 days, or they're, skipping periods now and then, I am 100% comfortable just watching that. But if it's random, unpredictable, any of the things that our colleagues talked about earlier this morning in the AUB lecture, I would biopsy. And then remember that new data about Black folks, that a thin endometrial stripe is not reassuring in those people. And it's because of the high prevalence of fibroids and non-endometrioid histology in Black folks. And so you really want to biopsy those people.
Great. Thank you. In a woman with no cardiovascular risk factors, history of breast cancer, etc., who began their HRT within a year after menopause, who continues to have symptoms such as hot flashes after 10 years, when you try to taper down, is there a reason we should encourage discontinuation or tapering of their HRT?
I think that that we need to listen to our patients, and that's just so common. That's a common situation, and one of the things I'll sometimes do in that situation is get an estradiol blood level. I don't do that routinely for people, but if I'm thinking that I want to taper them, in general, an estradiol level of about 30 is going to get you hot flush management. About 40 to 80 is going to get you bone and heart protection. And if you're going to do that, you want to do it the day before they change their patch and have them stop all biotin containing vitamins 48 hours ahead of time, because it will interfere with thyroid or estradiol levels. So some people are taking hair and nail vitamins and things. And so they have to stop that 48 hours ahead of time and get the blood draw the day before they change their patch. But, if somebody is 65, 66, 67, and they're wanting to stay on their hormones, sometimes they feel fine with a blood level of 15 or something, and so you can kind of taper them down and kind of find that sweet spot. But I don't worry too much if their level is kind of in that 20-30 range. I feel like, that's a small amount of estrogen and they're feeling better, but it is so individual, and you really have to have that discussion with your patient and kind of try to identify and then document the reason that you're keeping them on that. And if they're low risk in terms of other medical comorbidities, I think the risk of it again is so much less than obesity, alcohol intake, smoking, sedentary lifestyle, that I don't lose any sleep over it.
Okay, thank you. And then in checking that estradiol level, does it matter what time of day?
No.
Okay.
Just the day before you change the patch.
Right. Okay. Thank you. And is it okay to continue the Mirena IUD instead of provide oral progesterone?
That's a great question. You don't get much in terms of circulating progestin levels with a levonorgestrel containing IUD. So if you are dealing with a DVT or somebody that you don't want to give estrogen to, and you're looking at a progestin alternative, in that case, a Mirena IUD would not be equivalent to an oral progestin, because you're not going to get much in the way of systemic levels with the IUD.
Okay. Thank you.
Mm-hmm.
If we know that there's cardiovascular benefit for HRT, particularly for women less than 60, then why is cardiovascular disease still considered an absolute contraindication?
Hello, right? Hello. Thank you. And, and for, hormone therapy for prevention of chronic cardiac disease is given a you know what I'm trying to say. The U.S. Preventative Services Task Force guidelines, they give it a grade of D. And a bunch of us wrote in and said, please don't do that because we really do see cardiac benefits with it. And they said, absolutely not. And so it's not indicated for prevention of chronic heart disease, which I just think is too bad, because we think it really does. The ELITE trial from USC really showed us that when you start women on hormones under age 60, they have decreased coronary artery intima media thickness, so they decrease the deposition of atherosclerosis in their coronary arteries. So I tell my patients, when you start on hormones in that age, 15 years from now, you're going to have healthier heart, you're going to have better bones, so it's a shame that it really is not officially indicated for those things, but yeah, that's what we're dealing with.
So in your personal practice, if someone has a history of cardiovascular event, would you still...
That's still a contraindication. If somebody's had an MI, if they've had a stent, if they've had a stroke, if they've had a true cardiac event, then I don't, because that really does tip their risk to risk versus benefit, because we're talking about prevention. We're not talking about dealing with people who've already had an event. Those folks I would not. And the other question about breast cancer that I saw in the chat about what about the triple negative, triple negative breast cancers still have a 20% risk of transforming to estrogen receptor positive if they get metastatic disease. And so even the receptor status in a breast cancer patient really doesn't change my recommendation to avoid hormone therapy in most of those cases. That I thought that was an interesting question, and I wanted to bring that up.
Okay. Thank you. I really wish we had more time. Thank you for your expertise, Dr. G and Dr. Adams. We still have a lot more questions. If you guys could stay on and try to answer those virtually, I think everyone would really appreciate it. And so
I will just also say, Dr. Hung, that we are planning to do something like this 100% on menopause, and have a like a half day or 3/4 of a day seminar for this. So please, everyone, keep an eye out for that, because we would love to see back for that.
Great. I'll be there.